Hello everybody, I'm Kayley Ciesla, a Senior Research Fellow based within the NIHR Applied Research Collaboration for Yorkshire and Humber, currently based at the Bradford Institute of Health Research, and I'm presenting on behalf of the wider BaBi Network team today. Thank you all for being here. I look forward to presenting and learning more from this group. One of the research projects that I currently work on is the BiB4All cohort, which was the founding site for the Born and Bred in BaBi Network, a multi-site e-cohort, which I'll be discussing further today. I'm going to start with a bit of background to BiB4All and BaBi to provide some context. Many of you may be aware of Born in Bradford, but for those of you who are not, Born in Bradford is one of the largest research studies in the world, tracking the lives of almost 50,000 Bradfordians across 3 different research cohorts to find out what influences the health and well-being of families. BiB used these findings to develop new and practical ways to work with families and health professionals to improve the health and well-being of their communities. It has become really clear that one of the most important and useful sources of information in the BiB programme is the linked routine data that we collect longitudinally. This led us to ask the question, why aren't we doing this for all pregnant mums and babies? Now, it wouldn't be practical to have a traditional research-led cohort study on this scale, permanently recruiting. And so instead, we work with our local maternity service to train midwives in informed consent from research. And we added the consent question to join the cohort into the routine electronic patient record. This means that every pregnant woman has the opportunity to join, and there is not a researcher in sight. There are no long questionnaires or samples to collect, just their permission to use and link their baby's data over time. This new electronic data cohort is called BiB4All. The project aims to link routinely collected health, social care and education data locally to build a picture of child health and development. We hope that this creates a cohort for every generation. Since its launch in March 2019, NH midwives in Bradford have consented 5,625 women and 4,584 babies to the study. The primary aim of the network is to use routine data as a local health intelligence tool to inform and evaluate local policy and practice. As you can see from this diagram, which was created by 2 of the directors of the BaBi Network, there is a cyclical nature and process to the uses of data, and we constantly want to prioritise, analyse, review, improve and evaluate changes to services and interventions. So, what is the Born and Bred or the BaBi Network? So, following the successful implementation of BiB4All, we were approached by other sites who wanted their teams to develop their own local versions of the e-cohort. And as a result, the BaBi Network was established. This multi-site cohort study currently includes Leeds, Doncaster, Wakefield and East London. BiB4All is a co-ordinating centre, and we provide strategic research and support to each BaBi site to help develop the process to combine these local cohorts as a meta-cohort over time. Our long-term aim is to expand this model across further sites. As briefly touched upon, there are a set of primary aims that the BaBi Network is working towards, and these include harnessing the power of routinely collected data from multiple services and organisations to build a clearer picture of children and families' lives over time. We also want to create a series of electronic cohorts across the country that can be used locally as health intelligence tools to shape services. And finally, we aim to bring the meta-cohort together as one to answer research questions of national relevance. For example, we envisage the potential to explore things such as rare illnesses and conditions through the power of shared data and larger sample sizes that the meta-cohort will allow. So just to provide a little bit more information about the meta-cohort, these are the data sources here in this diagram that women are agreeing for us to link on their behalf. So in this example here, BaBi Doncaster would be responsible for all of these data sources in their site. And as a result, they become the data controller for this data set. The aim is to produce a series of linked data sets at each of the BaBi sites. So for example, BaBi Leeds, BiB4All, East London, Wakefield and Doncaster. The BaBi Coordinating Centre then aims to pull in anonymised extracts from each of these local data sets to create the meta-cohort. And the BaBi Coordinating Centre will then act as the data controller for the meta-cohort, Okay, so hopefully that has provided a brief outline of the BaBi Network and its intentions. On the next part of the talk, I'm going to focus on some of the challenges that we have faced during the establishment of the network. With such little time, I've chosen to focus on only 4 main challenges today. So firstly, I'd like to start with the process of developing and envisioning a meta-cohort. As you will appreciate, the complexity of putting into practice the varying elements of a functioning and translatable model is no small feat. We are constantly striking the balance between providing clarity in definitions and procedures without being too prescriptive that it limits involvement in the network. Because the consent model is embedded into routine midwifery practice, and this varies site to site, we need to balance the adherence to protocol requirements with the flexibility to ensure inclusivity. So, for example, one of the challenges we are currently working through is trying to define the data variables that we will require all BaBi sites to provide for us to the meta-cohort. With varying systems, ways of measuring and recording data, this is proving to be a difficult task. This is taking a lot of time and work to try and establish what the minimum information is that we need and what is possible practically to make the meta-cohort work. To overcome these barriers, we are working together across all sites to develop a minimum meaningful data set. Another issue that we often experience is the different interpretations and definitions of some core concepts. For example, issues such as information governance and GDPR are often interpreted differently between partners. This can sometimes provide blocks where some partners don't feel comfortable signing up to certain elements of the protocol if their organisations are more risk averse. This is inevitably going to be a continuing issue that we will need to navigate, as the bigger the network becomes, the more variation in opinions and preferences we are likely to encounter. Next, another area that is of contention is the electronic patient record systems. So there are at least 5 different maternity EPR systems in use in the UK. And trying to ensure that the different systems translate the informed consent process into maternity practice has been very complex. It is an ongoing battle to work with each of the software providers to translate the functionality so that it adheres with the protocol, but also fits with the day-to-day experience of midwives seeing and consenting women. And then the last challenge I would like to touch on is the limitations of routine data. As with any data source, this is largely subject to user inputting, and as a result, the data sets are not always complete or in the format that a researcher would like. This is further complicated by the fact that different sites may have different routine data systems. So, for example, if we wanted to find out how many prescriptions a child had between the ages of 0 to 3, Wakefield may use a different GP recording system to Leeds, and even within Wakefield, the GPs record their data in different ways. To overcome this, as part of the cohort, we want to work to improve routine data locally to ensure that it's as useful as it can be. This builds on other work we have done through BiB with the collection of perinatal mental health data to help improve the services for women. Okay, so for this talk so far, I've focused on the challenges, but of course, it is not by any means all negative. And the potential long-term benefits, outputs, and learning for the network and other longitudinal population studies far outweigh these. So, for example, embedding e-cohorts into routine midwifery care has highlighted the efficiencies of using existing structures to build a sustainable method to provide a cohort for every generation. Recruitment to the BiB4All study continued throughout the pandemic, whilst many of the research studies were put on hold, thus demonstrating its robustness. This is an important piece of learning that can be applied to the post-COVID world. Similarly, bringing together a multi-site cohort study of this nature inevitably means that the sharing of skills and expertise is magnified. We currently hold 6 weekly multi-site meetings that act as a community of practice to help the network develop. These have proved invaluable in problem solving, sharing good practice, aiding decision making, and progressing the network. These provide a great forum for checking in, allowing key goals and objectives and effective channels for regular communication, which is, of course, is crucial for any project to succeed. Similarly, these regular network meetings, alongside our attendance of other monthly individual site meetings, have allowed the development of positive and effective working relationships with all our BaBi sites. The improvement of good relationships cannot be taken for granted. It is without doubt the dedication of all the individuals involved that is enabling the success of this network. Something else that we have found to be incredibly useful is that we work in true partnership and collaboration with all our sites. By working together like this, we are able to come together on areas of shared interest. For example, developing training materials for midwives and applying for grants. One example is where the northern sites and their partners were successful in securing a data accelerator grant of £810,000 from the Department for Levelling Up, Housing and Communities. This is used to develop the data side of the projects. And this was only possible as we worked in collaboration and not in competition. Okay, so I think that summarises all I intended to cover today. So before we close, I would just like to acknowledge all the people that have made the BaBi Network a reality. First of all, it is only possible thanks to the generosity of the women and babies who joined the BaBi family and the enthusiasm and dedication of the midwives who invited them. We are so grateful to all the women, babies, health professionals and researchers who make BaBi happen. And secondly, I would just like to acknowledge the BaBi Network Coordinating Centre team, who are all amazing. The core team includes Maria Bryant, our Academic Director, Diane Farrer, our Director of Clinical and Research Governance, and Sally Bridges, our Programme Director. Without their direction, dedication, passion and vision, the network would not be possible. If anyone would like any further information about anything I've raised today, please do get in touch at my email attached. You can also find further information about the BaBi Network through our website, which is linked here. Thank you very much for listening today. I hope you found the information discussed helpful and interesting. If you have any questions, I would be happy to try and answer them.